During this session, we would like to also discuss some important information in relation to treatments and vaccines to COVID-19, as the European Medicines Agency will soon have a fourth public meeting for you to be able to raise any question of interest that you might have on vaccines or treatments for COVID-19. And we will discuss some elements, some aspects of these medicines and vaccines as a way to prepare you in case you would like to attend this EMA public debate. In what will follow, if there is any fact or information you disagree with, please feel free to express yourself. We all know that as we are both learning and acting with the treatments we have and the vaccines, more knowledge is coming in. Some things which might seem some true one day might change the next day, so it's perfectly okay to express disagreement, divergences, as long as this is based on facts and rational thinking. So without any further ado, as Davor explained, I will first explain the situation we are in Europe at present. What are the estimates in the weeks and months to come? And then we can discuss on treatments, vaccines, and pharmacovigilance. Feel free to raise your hand or chat questions that you might have when you want. So as I was saying, on the 25th of November, the European Medicines Agency will have a fourth public debate. They had three already, and that was a suggestion both by EURORDIS and the European Patient Forum to the executive director of the EMA, who immediately agreed back in November 2020 to have such public meetings with a large public. And these meetings are usually very well attended with thousands of participants. Some who register will have a possibility to raise questions orally, and others can have also a possibility to post questions in the chat. And this time, the EMA will cover the most recent news regarding treatments and vaccines in the EU, and we will see which ones are they reviewing at present. An update on safety information on vaccines, and the epidemiological situation regarding COVID-19 and the vaccination coverage in the EU. The EMA will also like to discuss misinformation on COVID-19 vaccines, and so that all representatives of the public, including those who hesitate with vaccines, can express their concerns and discuss with the EMA experts. So the meeting will be available online, and you will receive more information, or you can search yourself directly on the EMA website all the information if you wish to attend and listen to the discussions on the 25th of November. And the meeting will last for 2 hours and 15 minutes. But first, where are we with the situation in Europe? And I'm sure you've seen this data before, one way or the other, in your country or in other European countries. So this is the progress of the vaccination campaign as of May 2021. And in May, we knew already that some countries were ahead of others. The UK and Malta, they share the same sources of vaccines, and Hungary and Serbia, who had purchased vaccines from China and Russia. But if you look at all other countries from the European Union, the percentage of population covered was somewhere between 30, 40, and it was quite well balanced. And that is probably the first time in the history of the European Union that you see a health technology, here a vaccine, but probably that is also true for any other type of good, introduced relatively the same way on all European markets in all member states at the same time, giving equal chances to all citizens in the EU to access the vaccine at the same time. Usually for medicines, we have member states who are the first to be served and others who need to wait for long periods. And here, this is an illustration of what the European Union can do when they use what they call European joint procurement. This means the European institutions purchasing vaccines to manufacturers and distributing them to member states based on their needs, based on their respective populations. This can be done for health threats like this one. RRDs is advocating for the same kind of system to be adopted for orphan medicinal products, hoping that the European Union could also purchase orphan medicinal products in the future and be responsible for their distribution, a more equitable distribution to all people with rare diseases in member states, and to change the current situation where too often in many countries patients need to wait for long times, sometimes years, before they can access medicines that have been recently authorized. But back to the vaccines, we know that the situation has changed. In fact, since May, where there are different groups of member states with 5 leading the vaccination campaign: Portugal, Malta, Norway, Iceland, and Spain, with more than 80% of the population who received at least 1 dose of vaccine. And then Italy, Denmark, France, Belgium, and the UK with a 10-point difference with the 5 leaders, and etc. with Finland, Luxembourg, Sweden, Germany with 20 points difference compared to the 5 leaders. And this represents a huge population of people who are not vaccinated, and we know too well that the epidemic starts again. There is a winter surge due to the large number of people who have never been vaccinated, or the waning effect, the fact that for some vaccines, the efficacy wanes after 6 months after the second dose. That is progressive, but that is affecting all vaccines. And that's one of the reasons why now member states are proposing a 3rd dose as a boost to those who already received 2 doses more than 6 months ago, to be distinguished from the population of vulnerable people who have some conditions, some background diseases, where 2 doses are not enough to trigger the desired immune reaction to protect themselves from infection. So in this case, a 3rd or a 4th dose are needed to increase the levels of monoclonal and antibodies against the viruses to protect the people. But this is different from the waning effect in the population that already received 2 doses, reach a satisfying level of protection, but 6 months later, this is diminishing. But the lesson here is that the quite homogeneous situation we had in May is no longer the case. There are 2 large differences in the EU at present, and this is not caused by the distribution of vaccines. Many more vaccines were delivered to member states than that they were used. In fact, what explains these differences is the different demand in different member states for the vaccines. And this is illustrated here. Sorry for all these many numbers, but what you see in the first column is the names of the countries. The second column were public opinion polls done in February 2021, where they all asked the same question to citizens. Are you likely or very likely to get a vaccine when they will be available? And so we had a varying percentage of each population saying yes, from as low as 32 in Bulgaria to 89 in the UK. So that was what people said, declared they would do when the vaccines will be available. And the third column is the number of people who received at least one dose. And then in color, we can see the difference between those, if we take the average EU, where 64.4 said they would get the vaccine, and we have 69 who had a dose. So it's 4.6 points above the polls from February, but there are profound differences by countries, which can be explained by different factors. France, for example, in France, the difference is really striking. Many more people received the vaccine that said they would get one in February, but some other countries, like, for example, Norway, where they say that 89 were ready to have a vaccine, but 85 had the vaccine. So there is a kind of a deficit of 5 points, which can be explained for Norway, Finland, Sweden, and Denmark by the fact that the vaccination campaign was suspended due to some side effects that needed to be analyzed further according to their authorities. And the fact that the campaign was suspended and then restarted first introduced some delays, and secondly, did not help those who were hesitating to ask for the vaccines. In the UK, a possible explanation is the fact that one vaccine is more used than any other. It's the AstraZeneca vaccine, and people would like to have the choice, the freedom to choose another one from Pfizer, from Moderna, or from Janssen, because they fear some side effects related to the vaccine by AstraZeneca, but they don't have this freedom of choice. So that might explain why a large part of the UK population, despite expressed a high interest in February 2021 for a vaccine, is less vaccinated than we could have expected from the polls in February. On the next slide, so there are different estimates, different teams looking at what will be the situation in the next weeks or months, and we looked at several of these studies, but they all conclude the same. We will have a winter surge in Europe, which has in fact already started. We had a fourth wave, but now we have something else happening. So first, about variants. The only new variant that appears as variant of interest since the Delta variant, which is still the dominant variant in Europe, is called the Mu variant, and the WHO is monitoring this variant. We don't know yet if this variant will dominate over the Delta one, and we don't know yet if the vaccines will continue to be effective against the Mu variant. But this variant is being monitored. It could be that, in fact, if it is more fit than the Delta variant, that it would increase further the risk of transmitting the virus from one person to the next. And then there is this waning immunity with countries that vaccinated a large part of their population initially very fast, like in Israel. They're the first ones to see the waning effects, and large, abundant population-based studies showed clearly a loss of efficacy, and we'll see some data in a minute. And that is also true for different factors, like the rate of hospitalization, the severe cases or death. These changes when the efficacy of the vaccines is waning. So the different models that we will be looking at in a minute will be adapted because the situation varies quite fast, and they don't have yet in the model the impact, the success of the campaigns for the third dose. If this success for the campaign for the third dose is not high, then we may have a very high surge. So the different models, and if you're interested, you can, when you receive the presentation, you can look at the different sources that we've used. And today we will go through two of these different techniques to estimate the situation in the weeks to come in some countries. So as I said, there will be a winter surge. And so this is already a bit old from the 7th of November, but not all member states, not all European countries have adopted the same campaigns for the third dose. And you see different countries have started quite early. I think France started in April this year to propose a third dose. And these are the outcomes of this campaign as of early November. It's progressively improving, but in November, it means that all those who were vaccinated more than 6 months before, so that means all those vaccinated before May, lost some efficacy against the virus. So the first map I'd like to share with you from one of the institutes, the Institute for Health Metrics and Evaluation, is what they predict regarding the European situation for 31st of December 2021. And what you see on this slide is that in some countries, the number of patients hospitalized in intensive care unit beds, it will be higher than the number of intensive unit care beds, and sometimes by a very large factor. For example, in Poland, they estimate their needs to 22 ICU beds per 100,000 inhabitants, when they had only 7,000 before the pandemic, which means that in Poland, to face the situation before the end of this year, they would have to multiply by 4 the number of beds compared to before the pandemic, and by 4 the number of hospital staff, which is not something easy to do. And in these circumstances, we may have similar picture than we saw in India more recently this year, with lack of medicines, lack of oxygen, lack of basic equipment to have patients hospitalized in intensive care unit. But what is striking is that there will really be a divide between countries where there will be a surge, but moderate, and others, more Central Europe and Eastern Europe, where the surge will be extremely important, which is a concern because in 2022, we were supposed to have on the political agenda debates and discussions about a European unified healthcare policy, and particularly for rare diseases. PLWRD is planning a series of conferences to have a European action for rare diseases, but it could very well be that the public debate will be dominated by COVID-19 again, and more precisely by a divide between different countries within the EU, a situation that we did not see before. There were tensions in member states, but in all member states, whereas from now on, we can expect or fear a situation where there will be half of Europe with a more chaotic and difficult to manage situation than the rest of Europe. So that's just one map that summarizes the situation in the weeks to come. And here is the pandemic seen from the intensive care unit beds. And the first wave is at the top, and you have to see this as a wave coming to you. So these are all member states represented. Orange is the European average. So that was the end of the first wave last year, a second wave, a third wave, a fourth wave, which passed already. And this is the situation as of now. What you see, and that is the proportion of people with COVID-19 in ICU beds. In some countries, this was more than 100%, and that indicates the tensions, the efforts needed to to welcome all these patients in ICU beds. And some countries were clearly overwhelmed and saturated. But what is the situation here today? It shows an increase and a sharp increase. The names of the countries are difficult to read, but all the countries where you see a very sharp increase are from Central or Eastern Europe already. And that's the number, the increase of ICU beds occupancy, which means that the estimates we will see in a minute are already corroborated by actual data we can observe from hospital bed occupation. So if we look at Spain and Portugal, where the vaccination coverage is high, Portugal have more than 86% of their population fully vaccinated, and 85 is the minimum target. Ideally, it should be 90% in all countries. So, but Portugal is on the way to 90%. That's the situation as of today. So a low occupancy rate in ICU beds, and that's the situation in the weeks to come, with the low hypothesis and a high hypothesis. But in Portugal, because a very high part of the population is fully vaccinated, the surge should not be too high. And the increase will only depend on the success of the third dose. If it's not successful, then we will have the high scenario. If it's successful, then we will have the low scenario. A bit the same in Spain, except that there is a 5 to 6 point difference, and that already explains why the shapes are different. 5 to 6 point difference is million of people. And with this Delta variant transmitting easily from one person to the next, that can explain that in Spain, we have a low risk and a high risk scenario and an average scenario, but the situation can also be quite tense by February, March next year. In the UK, the fact that too few are vaccinated, and that's about the same in France. The fact also that once you are vaccinated, the efficacy is 90%, which means that 1 person out of 10 is not vaccinated. And then you have the waning effect. After 6 months, the efficacy decreases down to 60%, which means that 4 in 10 are no longer protected. And we've seen the same in Israel and Canada. So the estimates for January and February are an important increase again in the number of ICU beds occupied by COVID-19. And France bought a similar scenario. At present, it has started a bit to increase a bit again in ICU beds in hospitals. It's too early to say if we will have the low or the high risk situation. We'll see. But whatever happens, this will be within the limits of what we've seen before with the first, second, and third and fourth wave. It should not increase high above what you see is the fourth wave or the third wave at the beginning of this year. But now these are countries where, on the contrary, what is expected in the weeks and months to come will be much higher, much worse than has been observed since the beginning of the pandemic. That's the case for Germany, where according to these estimates, there could be up to 14,000 people in ICU beds. When until now, I think the maximum was 8,000. And same in Poland, where there could be as many as 20,000 people in ICU beds, whereas since the beginning of the pandemic, the maximum was 2,000. And already with 2,000 in Poland and 8,000 in Germany, both countries were overwhelmed during this peak. So with 20,000 and 14,000, the tensions will be even more acute. There could be more patients in ICU beds than any time before in Germany, Poland, and in other countries. Same for Romania, and same from Slovenia. And same for many other countries, but we will not go through all of them. All these simulations are available on the EIHME site. The absolute numbers might vary and might be different in reality, but I think the evolution will be what is shown here, because this simulation were right for the previous waves, and the model hasn't really changed now. And this is another way to predict what could happen, and this time this is from the European Center for Disease Control, the ECDC. It's an analysis they published, an analysis of risks they published on the 30th of September this year. And what they looked at is different countries which achieved different successes, different coverage in the vaccination of their population. Countries where fewer than 45% of their population is fully vaccinated, countries where it's between 45, 55, between 55, 65, 65 to 75, and above 75. But also they considered the national policies and the measures to control the spread of the virus, the physical barriers and other measures, with different scenarios where the transmission of the virus could be reduced by 60%, or on the contrary, the contact rates could increase by 20%. So depending on these two dimensions, on these two risks, the contact rates and the vaccination coverage, they could come up with different scenarios for different countries. The most optimistic is the top line, where according to 5 different cases, in 2, the risk will be manageable, will be within the current limits of what the healthcare system can face. 2, on the contrary, high risk, that the situation cannot be managed. But overall, on average, the risk will be manageable, but or high, but better situation than the bottom line. Few people vaccinated. In all cases, the situation will be at high risk to be unmanageable. And then you have intermediate scenarios. So this is what the ECDC estimates for November, December. It's the situation they estimated in September at the end of November this year. We have different policies for third shot in the EU. So what you can see here is the countries first where a third dose is only proposed for those who are immunocompromised or transplanted. So you have 13 countries. This may change month by month, and one country can add different groups, but that was the situation in October. 10 other countries had adopted policies for the immunocompromised and the transplanted people to be proposed a third shot, but also those of 60 years and older. And in some countries, they propose to switch to a different vaccine for the third dose, a different one than the one they received for dose 1 and dose 2. And there are other countries where this is still being discussed, or there are no discussion. And these are the countries that are the most affected, meaning the lower vaccination coverage. So there is clearly a lack of political reaction to the situation in some countries, who take too long to decide what should be done. Are there At this point, any question regarding the divide and the estimates for the next weeks or months? No? Okay, so I will continue now with what is new about medicines for COVID-19. And this was presented by Marco Cavalleri, who's the chair of the European Medicines Agency COVID-19 Pandemic Task Force, presentations to the Patients and Consumers Working Party at the EMA, or this is a member of, together with other organizations in rare diseases. And so at present, as we speak, the EMA started discussions, internal discussions about 219 different therapeutics. So that's a lot. It's a lot of work for the EMA to even decide which ones to focus the work on. There are 66 different vaccines identified for an interaction with the agency, some of which are already authorized, but many more are being developed and researched. In parallel to this, they need to complete what they call rapid scientific advice. This is when a developer would like the opinion of the EMA on how they should conduct their research in this very complex situation with many clinical research, many clinical trials, not that many centers able to do the research, a competition to reach the people at risk for COVID-19 or the patients who had COVID-19, which makes it extremely risky, and many clinical trials go nowhere. They don't enroll enough participants and then they stop, even if the questions they wanted to respond to were excellent questions. The EMA is also working on booster and additional doses. They're assessing the most recent data from different companies, and all these will be debated in November 25th meeting. They've started a rolling review, so they look at the data even before the developer of the Novavax, the Sinovac, and the Sputnik vaccine submit a marketing authorization. They look into the data that is available, that has been published already, to be ready if a company submits a marketing authorization, to be ready to adopt an opinion quite fast. And they also analyze the different variants, how they can affect the efficacy of the vaccines, or if there are subgroup of patients of special concern with some treatments. So regarding the different treatments, only one has been fully authorized in the EU, and you know this one, it's Remdesivir. Even if the latest data we have from the UK trial, the recovery trial, shows no effect, no benefit with the Remdesivir on mortality. You take it or not, the risk to die when you have severe COVID-19 is the same. So it's authorized, but I don't think it is largely used because the therapeutic role, the benefit of it is not at all clear. The EMA received marketing authorization applications for monoclonal antibodies and anakinra, which is more an interferon type of product. And we will look at some data about what this monoclonal antibody can do, how they can help, including people with some rare diseases. And they have started to look at data for other products. You've probably heard about Marineparaveer recently, and we will look at some data that they have and which we think is of interest. So without making it too complex, this is a slide to explain the potential role of monoclonal antibodies to treat the disease or to prevent it. We have what we call the passive immunization with antibodies, monoclonal antibodies. This is not largely used. This is only of interest when there is no vaccine. the idea there was to immunize a large part of the population by injecting monoclonal antibodies in the population. But this is not really a useful strategy here, because the population who would need to be immunized is simply too large. We had also some interest for convalescent plasma research, where you take the plasma of those who recovered from COVID-19. This plasma is full of antibodies that can neutralize the virus. And they tried to re-inject this plasma in people at risk for severe COVID-19, but this has shown to be not effective. So this strategy, you can forget it. So we have the vaccine, and we also have the PrEP, which is pre-exposure prophylaxis. This is often used in healthcare professionals who are exposed to the virus to increase their defenses. The idea is to inject them monoclonal antibodies so that in addition to the vaccine, and again, 1 person out of 10 who receive the vaccine is not protected. So maybe to increase further the protection, maybe to use monoclonal antibodies as a PrEP, or all patients, and that includes many patients with rare disease, whose response to the vaccine is not satisfying or who are contraindicated. There are member states, and we will look in some data, which propose these monoclonal antibodies for those who did not respond well to the vaccines or who can't have the vaccine. So day 0 is the day of infection. Right after being infected, if you suspect being infected, you can also use the monoclonal antibodies as a PEP. PEP means post-exposure prophylaxis. You think you received the virus, there is no treatment, you think that you have high risk of having a severe form of the disease, and that makes you eligible for post-exposure prophylaxis with monoclonal antibodies. And but there is only a short window, a short period during which you can benefit from these monoclonal antibodies. After this period, they are no longer effective to prevent the serious disease. And this is illustrated here on this complex slide. So it's one product, Regencov, Ronaprev. It's a combination of 2 monoclonal antibodies, Sutravimab and Indevimab, but which is only interesting in people who are not yet seroconverted, that is, those who just received the vaccine. They don't have antibodies yet, they haven't seroconverted yet. It's during these 14 days before your body makes antibodies against the vaccine, where when you are treated with this combination of 2 monoclonal antibodies, there is a clear benefit, a lower mortality in those who receive the monoclonal antibodies after D0 of infection. Once you already have your own antibodies, it doesn't add anything in terms of efficacy to receive these monoclonal antibodies. There is no benefit. So there is a very short period where this combination of 2 products can be really helpful. And that is particularly important for those who are at high risk of severe COVID-19. That's a new thing that we can do to prevent the severe disease. The cost for a 5 days treatment is around 1,000 to 2,000 euros per patient. In France, in the UK, the product received a conditional authorization in August, and in France, it is available via an early access program, precisely for all patients who have underlying conditions where we know that the vaccines may not be effective to protect them. So we have 50,000 people in France who are in this situation. They are now eligible for this combination of 2 monoclonal antibodies, and a few thousands have already started to receive a 5-course of injections to be full of antibodies in case they would meet the virus. Another monoclonal antibody is for adults and adolescents who do not need oxygen, but who are at risk of severe COVID-19. So they did a clinical trial in 1,300 volunteers. And you can see here the preliminary analysis. There were almost 300 receiving the placebo and 300 who received Sutravimab. Progression with severe COVID or death, 21, that is 7% in the placebo arm, and 3, that is 1% in the Sutravimab arm, which means a large reduction by 85% of the risk to die or to have severe COVID-19 when you are treated, when you receive Sutravimab during this short period where it can reduce your risk of hospitalization or death. So it's one product for which the EMA will probably share some information in November. These monoclonal antibodies may expose people to side effects. They have benefits, but they have also side effects, negative effects, which are important to know before they can be used largely in the population. This is another combination of neutralizing antibodies, which is from AstraZeneca. And this one has an additional benefit as a single injection could protect people from COVID-19 for a period of 12 months. So it's one injection and protection against the infection or severe COVID-19 for up to 12 months. So there is a trial in progress called PREVENT in the US, UK, Spain, France, and Belgium, where they already observed a 77% risk reduction of severe COVID-19 at 6 months after receiving the injection. And it's a convenient regimen. It's one single injection, which could be particularly interesting for those who have a rare disease or a condition like who are immunocompromised or who are using high-dose corticosteroids, which reduces the efficacy of the vaccines as an alternative to the vaccines. With this single injection, it seems to confer a high level of protection against the infection of the severe disease. The problem with monoclonal antibodies is that the worldwide production capacity is extremely limited. They are used for other conditions, for other diseases, and at present worldwide, the pharmaceutical industry is able to produce 30 tons of monoclonal antibodies in what is called bioreactors. They could increase a bit their production, but only by 33%. And that represents enough to treat 17 million people worldwide, whatever the need, whatever the indication. So we are already facing a difficult tension on the supply of monoclonal antibodies. And if tomorrow all industry has to mobilize forces to produce high quantities of these monoclonal antibodies to treat or prevent COVID-19, then we will all be facing a problem for all conditions. The idea is to ask these manufacturers to increase their production capacity, but then they're asking if we do so, what happens if finally we don't need these monoclonal antibodies? Who will pay back this investment if finally we don't sell more monoclonal antibodies? If there is an overcapacity tomorrow, who will pay for this overcapacity? So that's why discussions have started to disconnect the production capacity and the future users, and or to take this opportunity to produce more monoclonal antibodies for other diseases than COVID-19 and to increase access to monoclonal antibodies in all countries of the world. For the moment, the monoclonal antibodies are much more largely used in high-income countries than in middle-income countries or low-income countries. So it could, if we have another production, another capacity, it could be an opportunity to minimize this gap between different world regions. Molnupiravir is an adjunct close to remdesivir. It was initially designed for other viral infections like influenza or hepatitis. It's known to be able to act on the RNA of the vaccine, but also on the RNA of the human cells, which raises safety concerns. What you see here is a summary of the efficacy from in vitro or ex vivo studies. They treated patients for 5 days, and it's an oral capsule. And they compared 50 patients who received placebo with other patients who received increasing doses of molnupiravir from 200 to 800 milligrams. At day one, half of the blood taken from participants with placebo, almost half, in half of their blood, you could detect the virus, that's the red, and in half, you could not detect the virus. And at day 5, these were patients who were healing spontaneously. At day 5 in placebo, you still had 11% where you could detect the virus. In those receiving, let's go to the highest dose of molnupiravir. At day 1, 38% tested positive. You could detect the virus, but at day 3, only 2%, and at day 5, 0%, and a bit the same with half a dose of 400 milligrams. Not such a dramatic effect with the lower dose, 200 milligrams. But this efficacy from ex vivo data is far more impressive than what remdesivir can achieve. So already from the preclinical or from the large clinical trials, the interest for molnupiravir was higher than remdesivir. So this product it's not a new drug, it was invented 40 years ago. And probably here it could be useful if initiated early after either a diagnosis or a situation at risk of having received the virus. But in patients who could have a moderate or a severe form, not the mild forms, which is difficult to guess if you will have a mild, moderate, or severe form. But if you have at least one risk factor for a severe evolution of the disease, that could be the right thing to do to start a treatment with molnupiravir. And from what the manufacturer published in October, from a clinical trial which is in progress, there is a 50% reduction in hospitalization or death in the arm treated with molnupiravir. There were no deaths, and there were 8 deaths in the arm treated with placebo. So it could be much more useful than remdesivir for those who have at least one risk factor for severe COVID-19 disease. But as I said, because it interferes with the RNA, including the human RNA, it could be very toxic. It is known to be cytotoxic, mutagenic, and oncogenic. Merck says this should not be a concern because the treatment duration is only 5 days, and that should not be long enough to induce a detrimental effect of Molnupiravir on human cell, but certainly it could stop the RNA of the virus. What is bizarre, but not surprising, is that instead of having the classical cycle from clinical trials to marketing authorization evaluation by FDA or EMA, and then HTA to negotiate the price and to purchase the product. With COVID-19, we see everything completely reversed. It starts with member states, with countries purchasing a quantity of product and agreeing with a price, even when the clinical trials are still in progress. And then the product is authorized and can be used. That's the regulators to say. And then there is no need for an HTA because the price has already been agreed. And that is what is happening not only with Ronaprev, but also with Molnupiravir, brand name Lagevrio, where different countries like Australia or European countries purchase large quantities of the product to MSD even before MSD announced these preliminary results. So like if we were working the other way around, it should cost $700 for 5 days. This other product has only a code as a name, PF07321332. And this one was specifically designed to target the coronavirus, the SARS-CoV-2. It wasn't the case for Molnupiravir. Molnupiravir, again, was invented 40 years ago against influenza and hepatitis C, but not authorized for these two because too toxic. But here, this one was specifically designed for this virus. And it should be used in combination with another product, ritonavir, to increase the quantity of this product in the blood. And that's the bad news because ritonavir also interferes with so many medicines. And we will not have the drug-drug interaction with all medicines immediately. And so there will always be a risk, whatever the other medicines you are taking, of an overdose as soon as you take even a small quantity of ritonavir. So this product will not be easy to use for all those who have a medicine that is also metabolized by the liver, or alcohol even more. So they've completed just a phase 1 with this product. And again, Australia has already purchased 500,000 courses of this product only when phase 1 trials have been completed. We have no idea on whether it will be effective or not, but some countries already signed a price volume agreement with their producers. Whatever the price is, we don't know, but we don't know on which basis they decide to sign this agreements. So now about vaccines. So as you know, 4 are authorized in the EU. We have Comirnaty from Pfizer BioNTech, we have Spikevax from Moderna, Vaxzevria from AstraZeneca, and the one from Janssen. As we speak, no other company has submitted a marketing authorization, but the EMA has the curiosity and is exploring all data they can find for different other vaccines like Novavax, Sputnik 5, Sputnik V, or other institutes, other companies working on other types of vaccines. So this is the data the EMA presented in September, which illustrates the relative loss of efficacy of different vaccines. And here you see different colors for different vaccines, Pfizer, Moderna, etc. Initially, before the Delta variant was introduced, the efficacy was high, around or above 90%. Then the Delta variant appeared, and in addition to the apparition of the Delta variant, the fact that the efficacy wanes after 6 months shows that explains why in July, when this data was done, the efficacy was no longer in the range of 90 or above, but more around 60 and above. And for some, it was even less than 60. So whatever the vaccine, it seems that all exposed to Delta variant first, but more the waning effect, the natural production of the antibodies by the body progressively reduces unless there is a third boost. Is the reason why a third boost is absolutely needed, and these are population studies, and the same is true for all groups of the population. But as the elderly above 65 were the first to be vaccinated in most countries, they are the first to whom the third boost is proposed, and other younger groups will also be proposed a third dose in the weeks and months to come after the older part of the population will be fully vaccinated. How effective is the third dose? And this is illustrated here from a study done with the BioNTech, that's the Pfizer vaccine, the booster dose. And this shows that already 12 days after the third dose, you have a 12-fold increase in the reduction of the risk to be infected just 12 days after the third dose. It's very rapid. The antibodies are produced again in high quantities, and after 12 days after the third injection, you already are almost fully protected again. And then it continues to raise up to 15 or 20-fold reduction in the risk after the third dose, and it seems to be maintained. We don't know how long this will be maintained. It's too early to say if the third dose can maintain a high protection for 6 months, for a year or more. That is under monitoring, but it's too early to say. In vulnerable people, so there is a long list of rare conditions or frequent conditions where the efficacy of the vaccines is not the same as in the general population. Here, just one illustration with people who received a kidney transplant. Because they received a kidney transplant, they need to take immunosuppressant in order to prevent the rejection of the transplant. And because of this immunosuppressant, they don't respond well to the vaccines. They don't produce the level of antibodies they need to be protected against COVID-19. So after 2 doses, this population of people with kidney transplant received a third dose, and those in dark gray are those who responded to the third dose with an increase of their antibody levels, significant and enough to protect them. But that only is true for half of the people. The other half in orange, they can have a fourth dose, another boost, some of whom, in some of them, it will be effective, they will be protected, but there will be quite a large number of this half who will not respond to even a fourth boost. And a fifth boost will have no effect. It's really people who cannot produce antibodies against the virus. And these are the people for whom Ronaprev is indicated, the combination of monoclonal antibodies. If your antibody levels are not high enough after 2, 3, or 4 doses of vaccines, even if you switched vaccines, then you should be eligible for Ronaprev. The EMA has produced an opinion about that. It's a kind of opinion on a compassionate use. Some countries have a program where they have started to treat their population in this situation. They can't have a response to the vaccine, so they should be eligible to receive Ronaprev. It's a course of 5 days injection, and we have data on the efficacy. It is highly useful to help these vulnerable people. Now, the last part is about pharmacovigilance, what we've learned and how the EMA has organized the collection and the analysis of data on safety data on the vaccines. And what they do, and I will explain this in more details, because almost all of the population will have received the vaccine, it will be difficult to conduct the classical studies to see which new side effects occur in the population. So instead, they focus on what they call adverse events of special interest. Some of them are known, for example, the loss of smell, which is called anosmia, or other things like fatigue, which can be caused by the vaccine. These are adverse events of special interest. And they compare the number of cases that are reported, that are observed with these adverse events of special interest. They compare it to what is expected in the general population, which means that they know what is expected in the general population. And this is only because very recently, the EMA and other actors created all what we need to measure, for example, what is the number of citizens who lose the sense of smell or who have Guillain-Barré syndrome in general. Before the pandemic, what was the baseline rates of all these possible events? And they compare what we observe now that we have the vaccination campaign in progress to the baseline risk before the pandemic. And that's how they can measure if there is an increase or no increase of this kind of events. And we will see some examples of the results of this analysis. But in addition to all these, how do they process the new risks when they receive notification that there could be a new risk with the vaccine? First, they look at all the databases they have, and some of which have millions of reports from healthcare professionals or patients, people reporting directly their side effects. And they look in the data every 2 days. So as soon as something occurs, they can detect it in less than 2 days. They also contact international partners. They have a hotline with WHO and other international regulatory agencies. They ask the companies to submit safety reports every month. Usually it's every 3 or every 6 months, but here the different manufacturers need also to scrutinize all what is happening and to submit a monthly report to the EMA. And what is also new, the EMA has a special budget and they can fund pharmacovigilance studies themselves to explore with more precision what can be happening. And once something is confirmed that there is probably something that needs to be fully evaluated, they have a task force that is meeting bi-weekly, and they are in constant dialogue, the staff of the EMA working on pharmacovigilance, with the Pharmacovigilance Risk Assessment Committee, where all member states, doctors, and patients are represented, so they can analyze all the data that is coming in almost in real time. When they analyze all the data and they want to make recommendations, they can also commission independent studies at the request of the PRAC committee, and they can change all the information, the product information on the vaccines. With this, to improve the communication, they have monthly ad hoc safety updates on the website of the EMA, and they also have twice a month press briefings explaining all the new data that they analyzed. This is to illustrate the response of citizens and healthcare professionals to the call to report spontaneously the side effects that people have. And as of September, almost 1 million healthcare professionals or patients had reported spontaneously a side effect or several side effects. 62% of this million spontaneous reports were from patients. In most cases, in most of these reports, these are known effects, like pain at the injection site of the vaccine or fatigue, things that were fully identified in the clinical trials prior to the marketing authorization. But some were new and some triggered special attention and special action from regulators. And this is a comparison they did among people who had COVID-19 and people who had the vaccine. If you look, for example, this blue here, lymphadenopathy, these are lymph nodes which are bigger in size. It's much more frequently reported in people who have the vaccine than in people who have COVID, who are infected with the coronavirus. And that's normal. The lymph nodes are the organs where after the vaccine, you produce your antibodies and the immune cells active against the virus. If there is no lymphadenopathy reports, it could mean that the vaccine is not really effective. The fact that there are many more lymph nodes changing in size is an indication that the vaccine is active. If you look at myocarditis, there is an increased risk due to coronavirus. There were 11 myocarditis per 100,000 people with the virus, and 3 among those who had the vaccine. So the risk of myocarditis is slightly increased when you receive the vaccine, but it's much more increased when you have the virus itself. So even if the risk is now known to be higher in some patients, in the younger patients, and particularly I think with the Moderna vaccine, in all cases, this risk is much less than to have a myocarditis due to the infection itself. And the same reasoning can be made with all other side effects, like acute kidney disease. The risk seems even to be reduced by those who have a vaccine compared to those who have the infection. And this is another way to look at the data regarding this risk of myocarditis, which will certainly largely debated on the 25th of November, because member states, countries are adopting measures to further restrict the use of some vaccines when the risk of myocarditis seems to be increased. But the global picture is not worrying. Again, the people who have the infection have 6 to 18 times higher risk for myocarditis. But the risk of myocarditis is still 6 to 30 times higher among those who have the infection compared to those who received the mRNA vaccine. So in both situations, it's worth to receive the vaccine, even if it increases slightly the risk of myocarditis. This increase is very modest compared to the risk of suffering from myocarditis due to the infection. So they're not saying there is no risk of myocarditis when you are vaccinated. What they're saying is the increased risk following vaccination is far modest compared to the risk when you have the disease. And they looked at different types of events of special interest. And for different vaccines, they adapted the product information and the package leaflet. So if you're curious, you can read the package leaflet. And the package leaflet contains also precious information for some rare diseases, like there are some rare diseases which predispose to allergies when you receive a vaccine, like mastocytosis. So people who have mastocytosis should receive the vaccine only in their hospital and should be closely monitored. They should stay at least 1 hour at the hospital, and the team is ready to inject the treatments necessary to stop the allergy in people who have these diseases. So all this has been quite well identified and explained. And now we know that when you have an allergic reaction at the first dose, the allergy is much less severe when you receive the second and the third dose. So we have now all this new knowledge that we did not have from the clinical trials that the EMA would be willing to share and discuss with you if you connect to the meeting. So there is new information about myocarditis or pericarditis, about the capillary leak syndrome, about anaphylaxis, about thrombosis, about Guillain-Barré syndrome, and for other types of events, it's all described in the product information. I can stop here because it's already more than 1 hour of speak. Are there questions? We will finish before 4. There is a last chapter we could discuss. It's about the NIH program for long COVID, but I don't know if this is something of interest to you or not. Or we can stop the presentation here and take any question you may have about the treatments, the vaccines, or the evolution of the pandemic. I don't know if there are questions in the chat.
Thank you very much, François. Yes, there's a couple of questions from Dan from Alain Luxembourg. So I will go through them, and Dan, please feel free to unmute yourself and add anything in. So the first question was about about the number of fully vaccinated individuals that is still increasing. Is this caused by more restrictive measures taken by different countries or persuasive communication? And then also added that some skeptics seem to change their mind, but it is a race against time. And we will be interested in presenting the hard facts that are evidence-based that undermine those arguments systematically, but in a neutral way. Maybe add some explanation about scientific levels of evidence, etc. Is there such a reference document available that we could base our advocacy on?
Well, a complex question. The ECDC publishes a regular report on all measures, on all what member states do to propose vaccines to their populations. And the measures vary more and more by country, but they also explains what the barriers are. And sometimes it's more logistical problems that they're still having with some vaccines, but that was more the case at the beginning of the vaccination campaign. Now all logistical aspects are solved, and the explanation of the lower than expected vaccination coverage is almost 100% explained by people being unwilling to get vaccinated. Even in countries where initially there was a proportion of citizens who said they were willing to receive the vaccine, we see that it's not the case. We did not reach the expected amount of the population fully vaccinated in some countries. But there is no precise research country by country to try to understand why exactly, what changed, what made the mind of the population change to high proportion willing to get vaccinated, but at the end, a much smaller proportion who want to be vaccinated. Does this have to do with the fake news or the misinformation, or does this have to transcribe the fear to get side effects? Probably the side effects are difficult to explain. It's so easy to say, oh, there is a risk of cardiac arrest or myocarditis, so stop using the vaccine. Then to explain that it's true that there is an increased risk of myocarditis, but nothing compared to the risk caused by the virus itself. It is not something that can be simply explained, even if there are very nice efforts to use graphic visualization of these different risks. The communication of the side effects certainly had an effect on those who were hesitating. And that's why the EMA would like to discuss also the communication and the misinformation, what can be done to convince everyone to be vaccinated. But how to, I don't think there are precise guidelines on what can be done. There are many different programs. For example, the WHO has a project where they use artificial intelligence to detect on social networks when people are disseminating fake news on the vaccines. And with this program, the WHO automatically sends the correct facts to all those who received the fake news disseminated by the anti-vax campaigners. So the EMA could also learn from this initiative. The EMA is very good at publishing excellent information, but doesn't have the capacity or the knowledge yet to participate in these campaigns on social networks to try to mitigate or to lower the impact of the anti-vax. It's a fight of a war of different algorithms. These are things that need to be worked also with Facebook and other social networks on how to change their algorithm to favor more the information coming from authorities like EMA or WHO than the one coming from the anti-vax campaigners. But that's a long negotiation, which I don't think has really started with these social networks.
Yes, please, Dan.
Thank you. Sorry for the length of my question, which is really a mix of comments and questions. I feel that we have a responsibility to inform or make sure that people are informed correctly. And we are concerned now, especially with the third booster vaccination topic coming up, that some people might change their mind and not go for the third booster vaccination. The first statistics in Luxembourg seem to suggest that. So we are concerned that our patients could be misinformed by the traction gained by fake news on social media. And our thought was, should we not publish or advocate the hard facts, the counter arguments to those fake news based on maybe research literature, and try and keep it simple but still be complete at the same time. I know it's very challenging. I was wondering if there was any such document for reference that you would have available that we could use.
Well, what we have about the importance of the third dose is not in one document yet, but we will have some information presented by the EMA, and I presented some here already. I think it's really evidence which is not published by the manufacturers of the vaccines, because some will inevitably say, of course, Pfizer, Moderna have an interest to sell a third dose, so of course they do this research. But no, here it's in Israel. It's a population-based survey they made on all the vaccinated population that the healthcare system conducted in Israel, independently from the manufacturers, and they see clearly a loss of efficacy and the need to revaccinate everybody. I think that's something that maybe we could do to collect all the independent information ourselves, or request the ECDC to collect all this information. And I'm almost sure that they've started to do this work, to collect the evidence in favor of the third dose. But now I think part of what you are saying is true, that the anti-vax are disseminating dubs about the third dose. But I also think that we were all so sure that after 2 doses, we would all be safe and protected. The last thing we wanted to hear is that, oh, but now we have to do it all over again because it's not a long-lasting effect of these extremely effective vaccines with the mRNA one, but a very short duration. Other vaccines, life-attenuated vaccines, etc., it's 10 or 20 years of duration. Here, 6 months, it's ridiculously short. So that's why we need more research for long-lasting effects of vaccines, and to also have more evidence on the efficacy of the third dose. And one big part missing, but it has just started. It's another European initiative called Vaccelerate. They conduct research on all vaccines, and one is in Cologne, in Köln, to measure the duration of the effect of the third dose. For potentially, the third dose has a capacity to activate the cellular immunity, which could mean a protective effect for several years. But for the moment, we don't know how long the third dose can have an effect. And that's, I think, missing information for all those hesitating, because they don't want to have to go to get the vaccine every 6 months easily. I think it's also a good idea to link the vaccination, the third dose, with the influenza vaccine, the anti-flu vaccine. I think it's a good idea to propose it jointly for all those who get the influenza vaccine, except that even for the influenza, the flu vaccine, the history shows that all member states failed to reach their vaccination target. In the best case, the vaccination target was 45, meaning that 55% of the target population never was vaccinated against flu.
Thank you. And maybe let's go through the last comment that Dan made. Could some spontaneous adverse events be overestimated in comparison to other medications due to the strong public focus on COVID?
Well, it could be that there are some vaccines for which there were initial reports of side effects in high proportions, which turn out not to be actual facts. So that can happen. There are sometimes epidemics of reports of people after receiving vaccines for different conditions. But anyway, even with the best science, the best databases, the EMA is very well aware that all the estimates we can make of the frequency of the side effects are not absolutely true because of different factors. We don't know exactly the baseline risk in the population. We don't know exactly precisely if all those who had even a severe side effect, if there was a report made to authorities. We know that with traditional medicines, the very serious side effects like hospitalization, death, or requiring treatment are only reported in 10% of cases. So there are so different factors that can disturb the calculation of the risks that it's extremely difficult. But this is, I think, a valid question to also ask the EMA during the meeting. How do they calculate the risks? What is the level of precision or uncertainty about these risks, and what can be done to improve this estimate of the risks? I think these are excellent questions you could raise to the EMA. Over to you.
Okay, so we don't have any more questions in the chat. So I'm just going to invite everyone or anyone, if you want to speak up, now is the time. Just unmute yourselves and ask your questions. No, I don't think so. Dan, do you have anything more to add?
Maybe
Yes.
just more a comment, if I may. We are wondering if we should advocate strongly for a third booster shot for all vulnerable individuals. The problem in Luxembourg is that vulnerability is very conservatively defined. For example, if you have a degenerating neuromuscular disease, you won't be on the list of those vulnerable people. We have pointed out this before on 2 occasions, officially and publicly, but we don't seem to manage to change that frame of mind, and now we're a bit helpless with this.
And did you use the list of vulnerable populations produced by the European reference networks? Yes.
Yes, we sent all the references and we updated them on the material we found on the Eurodis website. And yeah, it seemed like this was something that they weren't too concerned about. The vaccine was rolled out in stages. We did a small survey to find out that more than 1/3 of people, more than 1/3 of those getting the vaccine, those stages were poorly organized. So that maybe the stage N+1 was already rolled out while the previous stage wasn't finished yet. And was a lot of concern, a lot of anxiety in our population.
Yeah, I could maybe share the link with the French health insurance system. They show for different vulnerable groups the percentage of the population fully vaccinated, and I think the neuromuscular diseases are part of them. For example, for the kidney transplant recipients, it's more than 90%. For amyloidosis, for other metabolic hereditary disease, for pulmonary disease, cystic fibrosis. Well, I'll send you the link, and I think that's something that can be useful to share with your authorities, to ask them how can we reach similar protection, and that's only for 2 doses. On this analysis by Data Vaccin COVID.Amélie, it doesn't address the 3rd dose, but it shows that when you want to make an effort to protect the vulnerable populations, you can reach very high coverage numbers. Now, what more with the third dose? I think you can also maybe discuss with the authorities the possibility to have a compassionate use to Ronaprev. It's easier to use a third dose than monoclonal antibodies, but you have all the rationale, the scientific rationale to use monoclonal antibodies in those who are vulnerable to and who don't respond well to vaccines that I think you can use to make your case for the first dose. As suggestions. Stefano, you have a question?
Yes, it's about the third dose. I'm a transplant recipient, and I already made the third shot. But at the beginning, most of us were not very sure about that. But I can say that all our members, we are lung recipient transplanted. We all are making it. I also made the exam to count the antibodies, and I'm one of the few transplanted people who, both with the second dose and with the third, I developed a good number of antibodies. But my question is about the pharmacovigilance, because as the third dose was mainly made to transplanted people, not people, I think there should be a particular vigilance on our organ recipient, because we are our immunological system is very difficult because of the drugs, no? And we really don't know if we will have different problems than the normal people, because we have, for example, the risk of rejection. Some of us have this fear. So I'm asking everywhere in every discussion that we need a special pharmacovigilance for the solid organ recipient.
Yes, thank you. I think maybe not all, but most centers of expertise, they follow up carefully their vulnerable patients, and they collect data and they share the data with the regulators. I think this is happening already. So I don't know if that's the case for all centers of expertise or how the European reference networks organize themselves to pass the information to EMA, but that also could be a question to address to the EMA at their public debate. What are the sources of information, and if they receive reports, including from centers of expertise in rare disease, where we know the people are either vulnerable because high risk for severe COVID or vulnerable because high risk of the vaccines not being fully effective. Something else that can be done also in Luxembourg, I think, even if we don't know exactly what is the level of antibodies you need to get to be protected, I saw some data where they use the unit BAU, binding antibody unit, that's the WHO unit, BAU, and the threshold is around 250. If you test your antibodies after 2 doses and you're below, then you should be eligible for a third dose, even if you don't have a known underlying condition, or even if you don't take corticosteroids. Below 250 BAU, you're not protected well enough against the virus. You have to be above 250 BAU. So that could also be an alternative to discuss with authorities, to have antibody testing easier, more general, or less expensive for those who think they could be not, or want to know if they are fully or well protected by measuring their antibody levels. And if not, propose a third dose. I think that could be an approach.
Yes, just the last thing. I'm sure that all the specialized centers are making this kind of test on the antibodies, and we are making them also ourselves inside our organization. We all make the test, so in order to have the result a little bit earlier, because we don't, you know, it's very long to receive the result, no, from the biggest studies. But I mean, not only on the antibodies, but on the side effects. We need in special studies, because we are different than the normal people. So it may happen that we could develop different side effects.
And that could be part of the studies commissioned by EMA. So again, one valid question to ask the EMA on the 25th, which kind of studies did they commission? Did they commission pharmacovigilance studies among some populations like the one you describe, or other rare disease populations?